Sir, we are live now. Shall we start?
Yeah, I'm ready. Shall I share screen?
No, sir. First, I will introduce just one. So, good evening, doctors and all the participants. I Sumon on behalf of Shield Healthcare, welcoming you all in another very interesting and informative topic that is urinary tract infection and its impact on the women's health. And our guest speaker is none other than Dr. Samir Hajra sir, and it's our pleasure to have sir on this platform, Shield Connect. And now it's my honor to introduce sir. Sir is the senior consultant obstetrician and gynecologist in R.C. Hajra Memorial Hospital, Dhanbad. And in terms of academic activities, training, and attending many conferences and workshops, there has lots of experience and attachment in the medical sessions also, apart from her clinical practice experience. And with many awards, sir already got throughout his entire clinical practice time period. And recently, a national award also got, sir also got national award that for Best Hospital Administrator from Six Sigma Military Academy by Health Minister and Defense Ministry at New Delhi. So with the short introduction, I request sir to take over the session, and meanwhile I request all the participants for your active participation and please focus on this topic. And after the completion of the talk, then we will have some short discussion on this topic based on the question put by the doctors in our Shield Connect platform. So thank you very much once again, sir, for your valuable time and for our time to spend in this platform. And thank you very much, sir. And over to you for further proceedings. Thank you very much.
Yeah, first let me. Just one second, I'll just upload the
Sure.
Okay, am I audible now?
Yes, sir. Yes, sir. Everything is fine, sir. Thank you.
First, at the outset, I just want to thank Shield Healthcare along with Mr. Biplab and his whole team, consisting of Sumanda, Bharat Bhai, and the special thanks to the whole team supporting the CME by our Shield Healthcare. Nothing can be feasible or we cannot expect anything better until unless we are being well supported by pharmaceutical companies. And for that, I really, like from my heart, I thank Shield Healthcare, so kind enough to support and to carry our message to our would-be mothers or our healthy females or our women as such. UTI, the topic today is a burning topic, and every day in out, every woman in lifetime, at least 3 to 4 times, they suffer from this disease. It's a very common disease, but well hidden. Female, they feel shy. They never try to look into it exactly what is going to happen if something doesn't happen. What I'll do if doctor wants to check inside if he's a male gynecologist. So many problems are there. So generally, we always try to see, okay, fine, how best we can help our ladies and how easy we can be. And for that, again, I'll ask Michelle to be, we are really thankful for your initiation, and let us continue with our topic. I am Dr. Samir Hazra, CEO cum Medical Administrator of Hospital for Women, which is situated in coal capital of India, which is Dhanbad. in Jharkhand. I'm trained in microvascular surgery as well as microsurgery, gynae oncology surgeries, breast cancer surgeries, as well as I do practice in my daily as a high risk obstetrician as well as gynae surgical team. I've got my own team. My wife is ably supporting me in all spheres. Infertility, assisted reproductive therapies with IVF and laparoscopy as well as endoscopic surgeries. Basically, apart from my academic things, I do take care of my medical administrator. Along with them, I take keen interest on lead auditor course. Also, we do give certification as well as I do audition for NABH as well as I'm a black belt Lean Six Sigma masters, and I just train people, doctors for Lean Six Sigma. That means highest degree of perfection in our operative field. I'm trained from XLI Jamshedpur for advanced finance management. I'm trained in lead auditor course for quality care as well as hospital dealing with medical services and do lead auditor course. So our burning topic today is UTI, the woman health. UTI, if you ask anybody, any female at their own career, from starting from around when they become conscious, from around 8 years till around till death, they will suffer from some burning sensation to itching. So many things are there, but they feel shy mostly because this portion is generally covered by maximum clothes in any person. We do all the coverings, and that leads to massive like aeration defect and so many things. So basically, the structures which suffers are urethra, which passes the urine, the bladder, which stores the urine, ureter, which brings the urine from kidney, and the kidney, which is the master gland. So all these four things makes the lower urinary tract, bladder and urethra the most. So generally what happens, women at the age of around 20 to 50, at least 3 to 4 times in their whole lifetime, they will have this problem. So basically, we need to understand 30% of all women will suffer. 40% at some point of time is always at risk. 1 in 5 women between the ages of 20 to 60, they suffer at least one attack per year. It's such a common thing. And approximately 30% of pregnant women will suffer from UTI. So we need to understand how we have classified the risk factors like UTI causing things like from iatrogenic drugs, behavioral pattern changes, anatomical and physiological defect, as well as genetic. Like iatrogenic drugs, mostly indwelling catheter. In any operation or anything we do, catheter is always catheterized. If we are not cleaning properly, generally we suffer. Antibiotic use, overuse of antibiotic, overuse of required medication. Nowadays we see of late so many because of pharmaceutical pressures and so many things and corporate hospitals, we misuse antibiotic like anything. Other than that, spermicide also helps in like causing irritation and attachment to the E. coli, which is the most causative organ for this UTI. Other behavioral pattern changes like voiding dysfunction or frequent or recent sexual intercourse. We should be very cautious in respecting our urinary tract system like penis or vagina, anything. At least we should have this much of courtesy to whenever we pass urine or all this, we should clean it. Muslims have got a very nice practice of like soaking the droplets of the urine so that it should not stick to their pants, and it's a very nice practice as far as I feel. Second thing, when there is some anatomical deficiencies like vesicovagal uteral refluxes are there in female, our short urethra, pregnancy itself slows everything. It's all again a progesterone mediated smooth muscle relaxation, which leads to storage and non-passage of non-evacuation of urine as such. All these things leads to urinary tract infections. Basically, genetic also cause an important part. The UTI occurrence tend to clusters in families. In one family, if you see, most of the sisters and maternal or paternal or anything, they will have a association, and it is mostly we should understand that susceptibility to the uroepithelial cells secretes less amount of IgA. which is the main humoral defense mechanism and is as far as physiological mucosa is concerned. And the properties of vaginal mucosa may allow E. coli binding more readily. That is why now of late we have got a like some phyto extracts are there. We are much better off in taking care of patients with all those things. Basically, we should understand the etiology which is responsible, like E. coli, Klebsiella, Proteus mirabilis, Pseudomonas. These are the age-old factors which were responsible for UTI, but still Escherichia coli they make, or E. coli, what commonly we call as, is 75 to 95% of all the positive organism. Other gram-positive bacteria which are less often is Staphylococcus saprophyticus, Enterococcus faecalis, and Streptococcus aglyksis. See, Enterococcus faecalis, it is generally an ascending infection from anal canal. So we has to be, whenever a patient is hospitalized, we see the E. coli accounts for 50% of things. Other than the E. coli are our Klebsiella, Proteus, Enterobacter, Pseudomonas, Serratia, as well as see, we need to understand one thing, even whether it is hospitalized patient or we need to take care of our vaginal or the urinary tract system very nicely, but nobody else is there to save us if we can't help. So basically, if you just look at the pathogenesis, see all these things, many of us know also. So I need not go in detail. So basically, we see what from the vaginal orifice or from the penile mouth, it enters into the uroepithelial system of the bladder. From bladder, it enters. See here, one important thing as far as males are concerned, males we have got 25 centimeter length urethra, so it is much safer than female who has got hardly 1 inches. So these are the things which we have got little advantage over female, but still urothelial penetration as well as ascension, it leads to pyelonephritis, and at last it leads to acute or chronic kidney injury. So basically, we need to understand the part of urinary tract which is involved, like kidney. If we take this, mostly the moment it get infected, that means it is the last stage, whereas it has already. And generally, as far as UTI is concerned, we should know UTI ascending infection is the most commonest route. Then coming from hematogenous route, like from the systemic human body system or other things, or from any trauma from external sources. Kidney is the last organ to be affected, and the moment we get flank pains with high shaking or chilly fever, nausea, vomiting, we should be cautious that okay, fine, we are dealing with a kidney nephritis or nephrolithiasis or something like that. Second comes the bladder. Bladder, it's very easy because it will be the pelvic pressure basically, and lower abdominal discomfort, as well as frequent and painful urination, as well as we may see hematuria or blood in urine. Last but not the least, urethra. Urethra is the first organ which gets in touch with the outsource, and burning with urination or itching or redness or soreness or painful urination, as well as with whitish discharge. These are all common features of our urethritis. So uncomplicated UTI usually considered to be cystitis, the first thing, and then comes pyelonephritis, and which occurs. See, basically, we need to understand premenopausal women will have a different type of thing. Postmenopausal women will have a different type, because hormone main, which is the main source which gives that elasticity to our tissues, they are gone off with the postmenopausal. That is why many of patients we come across stress incontinence or urge incontinence following menopausal stage. So UTI can involve either sex at any age. This needs to be understood very clearly. Patient may be a child or maybe a pregnant lady. Patient has to have any or some of the following features, like structural or functional urinary tract abnormality has to be there, or obstruction outflow, urine outflow should be there. Comorbidity that increases the risk of acquired infection. When patients are admitted in hospital, all those things we need to keep into our mind, or is resistant to treatment, or so what we really call the poorly controlled diabetes or chronic kidney disease, kidney disease, or immunocompromised patients. They are much more susceptible to the urinary tract infection. The recent instrumentation or surgery in and around urinary tract or in the lower pelvis area, they are bound to lead with our urinary tract infection. Basically, it may follow a complication also like recurrent skin infection, recurrent infection, especially in women who experiences 2 or more UTI in last 6 months. They are more bound to get within a year. Permanent kidney damage from acute or chronic kidney infections due to untreated UTI is also seen. Increased risk in patient due to delivering of low birth weight baby or premature infants. Sepsis or poorly life-threatening complications of infection is also seen. See, generally, this third portion, the increased risk in pregnant women with delivering low birth weight. See, this is the most commonest, most gynecologist or obstetrician they have. Most of the gynecologists which I have seen, they deliver in premature because of this UTI only. So diagnosis is very easy. Urinary tract infection, upper or lower or simple or complicated. It's very easy to diagnose because we need to take a very clean catch urine and it has to be a midstream urine and specimen has to be see if a operative patient we have to catheterize and collect the urine. That's the best practice. Or else because it's very difficult to take the midstream sample. And if a sexually transmitted disease is suspected, the urethral swab for the STD is also obtained prior voiding. So the test, urine test, what we are using is dip test as well as microscopic examination for pyuria and so many things. If pyuria is there, if the WBC count is more than 10, we take it as a pyuria. And if the presence of bacteria or absence of pyuria with contamination like more number of pus cells or epithelial cells or granular casts are there, we have to be cautious. In microscopic examination, again we can see microscopic hematuria also occurs in 50% of patients, as well as gross hematuria can be seen. WBC cast like pyelonephritis or glomerulonephritis or non-effective interstitial nephritis can also be seen, as well as in pyria in absence with bacteria or UTI is also possible. And this is the most dreadful condition when we get a in absence of bacteria, we are seeing pyria. So cultures are very commonly recommended, and generally whenever we find complicated or uncomplicated UTI, the first indication of bacteria, generally moment we see patients with pregnancy or postmenopausal women, men with recent genital manipulation, pubertal children, pregnancy, patient with urinary tract abnormalities or recent instrumentation, or patient with immunosuppression or significant comorbidity, or patient with symptoms suggesting a pyelonephritis or sepsis, or patient with recurrent UTIs. These are the group which has to be needed to monitor properly, and they need to be always taken for granted that these are the potential UTI patients, and we need to see them very frequently and as early as possible, and to start treatment as early as possible. The urinary tract imaging choices includes ultrasonography, CT, intravenous urography. Occasionally, voiding cystography or retrograde urethrophy or cystography is warranted. Children with UTI often request imaging, and most adults do require assessment for structural anomaly unless patient has less than 2 episodes of pyelonephritis. Excuse me. And nephrolithiasis is suspected, or there is a painless gross hematuria or renal insufficiency, a fever persisting for more than 72 hours. We need to be cautious. See, differential diagnosis has to be there, like acute urethral syndrome, which occurs mostly in female women, and it's a syndrome involving dysuria, frequency, pyuria like pyria dysuria syndrome, and thus it resembles cystitis. However, in acute urethral syndrome, unlike cystitis, often urine culture are negative, and this is where we get confused again. Urethritis is a possible cause of causative organism being chlamydia trachomatis and ureaplasma ureaticum, which are not detected on routine urine culture as such. Non-infective causes like anatomical abnormalities like urethral stenosis or diverticulum, physiological abnormalities like pelvic floor dysfunction or repeated pregnancy leading to vault prolapse or so many things. hormonal imbalances like atrophic urethritis or postmenopausal ladies, localized traumas, GI symptoms with inflammation. They are all causes of non-infective causes. So management is very simple. Urethritis, see, still now, whatever we say, however whichever mode of antibiotic or which generation of cephalosporin group comes, doxy will always be remain the drug of choice. Along after that, uh, azithromycin is there, and cefotraxone. Cefotraxone is 250 milligram IM is given, plus either azithromycin or doxy has to be given. First line of treatment for cystitis or uncomplicated cystitis is still nitrofurantoin 100 milligram per oral twice daily for 3 to 7 days. Trimethoprim, sulfamethoxazole, still Bactrim DSP call it the age-old method or age-old treatment, and still many patients after becoming resistant with norfloxacin or nowadays even quacks, they have also started writing metafloxacin or norfloxacin or gatifloxacin. Even I have seen recently one patient has been writing quack writing levofloxacin, when everything, but you name anything. Now quack has got everything to treat with, and that is why whenever we get a patient, we get with drug resistant UTIs. Pyelonephritis is a common, it requires antibiotic, which is a must. And must. Generally, we need to categorize how emergency it is and how much we need to do like which patient is for outpatient treatment and which patient requires antibiotic therapy to what extent. Patient are to be explained with the expectant module, and we need to understand that adherent to the treatment is required. Patients, if the patients are immunocompetent, we need to check for the medication which we need to give. Patient may have nausea, vomiting, so many things has to be side thing has to be taken care of. And patient who have no factors suggesting of complicated UTI, we need to be more cautious. Like ciprofloxacin, 500 milligram BD for 7 days is sufficient. Our second option with using Bactrim DS or trimethoprim, sulfamethoxazole 160, 800. Again, it is given for 14 days. These are all older medication, but still we have to have some faith, because now again I'm telling with the quacks introduction, we are mostly getting resistant with all higher antibiotics. So even I've seen in my regular practice, bacterial or trimethoprim, sulfamethoxazole, 14 days I give BD, patient is fit. Main thing, urine, 4 liters of water. Nowadays I've added, after corona's inception, I've added ajwain to the 4 liters of water per day. Along with that, lemon I ask them to take with jaggery and jaljeera powder. So alternative medicines. See, now we need to understand, in this era of costly medicines and quack disturbing our like happy sleeping moment in the night. Patient comes and calls us in the night, sir, abhi tak kuch nahi hua, we are not better off. We have taken this much costly medicine. We have taken, we are not better off. Irrespective or not telling us the truth that they had been already partially treated or ill treated by quacks or some other. So now we need to think of some alternative medications which will support, or which general medical people or quacks they might, or RMPs, they might find it difficult to copy. These are the like cranberry concentrates, as well as this ural or arsocolic acid for a urine alkalizer. So basically, along with trimethoprim, cephalexin, amoxicillin, clavulanate group, nitrofurantoin, we have got for non-pregnant patients, we can give so many like, just like general patient, we can treat with all those above things what we have seen, like trimethoprim, sulfamethoxazole, cephalexin, amoxicillin, clavulanate acid, nitrofurantoin. Nitrofurantoin generally, which is supported for chronic UTI, also we give. Achha, antibiotic treatment for lower urinary tract infection, because this lower urinary tract infection is very common, and mostly for female patients and non-pregnant patients. If you don't treat, it becomes asymptomatic bacteria, and which may respond, and it may fail to respond to our general antibiotic therapy. So in these cases, generally we need to ask patient for more of this cranberry as well as arsolic acid group. Particular care should be taken for prescribing nitrofurantoin in elderly patient as well as who may be at risk of toxicity. And we need to understand that urine culture to guide or as a base to our antibiotic therapy has to be there, but until unless it responds, we need to check quite often. And nitrofurantoin, all those things needs to be given for chronic use. Symptomatic bacteria, standard quantification of urine culture has to be done the moment patient comes to us as a first standard antenatal checkup or as a baseline, and confirm the presence of bacteria in urine in the second urine culture has to be there. And two things: do not use dipstick testing for screening bacterial UTI for the first or subsequent time. Always it should be done with our local pathological way of doing microscopy under microscope. And treatment of asymptomatic bacteria in pregnant women with antibiotic is a must. So like in pregnant women, antibiotic therapy generally what we do, we see like amoxicillin, cephalexin, augmentin. These are grouped there, and amoxicillin thrice daily, cephalexin and augmentin, all those things, BD, 3D. And see, we have got galaxy of medicines, but we need to be judicious. But nowadays, at the advent of cranberry and arsolic acid and all these things, we have our usage of medicine or antibiotics has come down like anything. See, these nutraceutical choices, additional choices for UTI has been named in many papers. Mr. Lockwood at AF, they have done a lot of papers along with, we were in the international meta-analytic study with cranberry along with our arsolic acid group. And our findings were, it's bound to come up in another few days. These arsolic pharmaceutical properties are, it's a very powerful anti-inflammatory as well as analgesic effects is there. It inhibits pro-inflammatory cytokines and tumor nuclear factor alpha as well as prostaglandin E2, an anti-inflammatory effect of it, which is comparable with the indomethacin or powerful NSAIDs and powerful antioxidants, and it prevents tissue damage and inflammation due to ROS and rapid. See, basically, this arsolic acid and cranberry, these two are a great boon to us nowadays. And it, when any formulary which has all these things has to be taken for granted nowadays, and it is of demand. And I'm seeing nowadays, when we try to avoid giving medicines in many cases, but arsolic acid as well as our cranberry, they suffice our treatment, and it reduces the efficient failing to treatment. See, like so many local application with salvia officialis leaves, this is arsolic acid and all those things, and an innumerable number of papers has been published, and all suggest only one thing, that along with antibiotic, give lesser dose of antibiotic, give more of this anti-inflammatory effect of arsolic acid as well as cranberry. It improves, and it not only improves, it betters the patient response to our medication, and recurrence is little less. Again, see, like potassium manganese citrate, fungal properties, potassium magnesium citrate and K-mag solution, it produces high concentration of bicarbonate in urine, alkalizing the urine, and this naturalizes the acidic urine of the infected urinary tract, and it reduces the burning micturition. Again, D-mannose is another great boon to us. This D-mannose is a similar to structure to the binding site of urothelium glycoprotein receptors, and basically what happens, this D-mannose, it does not remove, it removes and blocks this femoral portion, so that this adhesion system, its saturation of the adhesion system, it prevents bacteria to again getting reinfected. That is why with D-mannose or cranberry thing, we get a very nice response from our patient side. And recurrence is very, this PAC or proanthocyanidin, this contains fructose inhibitors, which binds to type 1 fimbria to the uroplantin receptors, as well as proanthocyanidin preventing all these fimbria, urothelial fimbria to the glycolipid receptors, and they Physically, they go for a competitive so that it does not allow the E. coli to stick to the fimbrias. Again, for prevention, again we need to understand one thing very clearly: that 4 liters of water has to be drunk. See, we cannot treat UTI without advising for drug, because the main infrastructure or the basic of UTI, getting a betterment of the UTI treatment, is drinking of water. And 4 liters of water has to be taken for granted. It should not be left aside. Along with it, vitamin C containing your lemon. Lemon is the main and the very good source of vitamin C, along with your other citrus fruits. But still, lemon edges past everything. So plenty of liquid, especially water, and along with cranberry juices, it wipes from, and the vulva, the urethral area has to be clean, wiped from front to back, not from back to front. And empty your bladder soon after intercourse. That has to be practiced very keenly. And avoid potentially irritating feminine products, and change your birth control method if you find UTI is impending on you. Postcoital prophylaxis has many patients they prefer, but still water along with all this dimenos and your arsolic acid, as well as our this medication, these nutraceutical products, they help us in reducing the antibiotic as well as patient's compliance or patient's acceptance to our treatment protocols. UTI are temporarily related to sexual intercourse also, and usually single dose of one drug used for continuous prophylactic, like your nitrofurantoin, all those things can be given, or doxycycline, total double dose, or minicycline can be given. In postmenopausal women, antibiotic prophylaxis is similar to that described previously, again as we have already discussed, and topical estrogen therapy has to be given in our postmenopausal ladies, because it improves the vascular blood supply. To summarize, urinary tract infection is an infection in any part of urinary system. Females are more prone because of its short urethra. 40% of all female will suffer at least one at some point of lifetime. Though incidence of bacteria in pregnant women is very highly than non-pregnant women, the chances of progression of pyelonephritis is significantly higher. That needs to be, it goes up to 40%. We need to be very cautious about it. And high chances of pregnancy complication is there, because most of the preterm labor is due to this urinary tract infection only. First line, because what you see, bladder is very near to cervix, and in cervix, the amniotic membrane is very closely opposed to the cervical area, a lower segment, what we basically call as. And high chances of pregnancy complication is there. That is why. And first line therapy includes antibiotic, and antibiotic has to be given. If antibiotic is given along with arsolic acid and your D-mannose, cranberry, we get the best out of it. Nutraceutical provides relief from pain, burning sensation, and first flushed out bacteria. So that helps us. Thank you very much. I think it's a very concise way, but still, again I'll say, please, to all my doctor colleagues, incorporate arsolic as well as D-mannose in our system, like cranberry component, and it will reduce your antibiotic therapies. It will reduce your chronicity of UTI. It will stop using nitrofurantoin for 6 weeks to 6 months. Thank you very much.
Thank you very much, sir, for this nice presentation, as you covered almost all the things related to this very important and emerging topic. So, sir, if you allow me, then I can take the questions.
Yeah, sure.
Thank you very much, sir. Sir, one question is there as maternal genitourinary infection, maybe during this pregnancy, is another leading cause of preterm birth or stillbirth. So, to reduce this problem, what will be the appropriate approach for treating this?
That is what say. First is water. Second is cleaning the vagina post voidal thing. Third thing, if you become positive, if your urine microscopy says full of microscopic presence of bacteria, or your pus cells and epithelial cells, as well as if we see local presence of hematuria, we need to give, like I have been using UT Plus from your company's thing, and I've routinely, whenever pregnant ladies come, and I've seen a very nice response to this UT Plus along with that. And hardly I give antibiotic along with UTI Plus, because then I'm getting a very good result with it.
Thank you very much, sir. And sir, another question is, as in case of this postmenopausal woman, there will be
Yeah,
decline
again,
in the
one thing about
estrogen and
again, I'll tell you. See, at the
yeah.
second or last phase of pregnancy, generally we try to avoid antibiotics. And for that, this thing, UT Plus and all this medication with all the nutraceutical things, they help us a lot. And it really like allows our female also not to take much of antibiotic, which might not be conducive or which might not be helpful to the patient for the baby's sake.
Yes, sir. Yes, sir.
Yeah.
Okay,
And
sir. Thank you. And sir, another question in case of this postmenopausal woman, as the estrogen level will be low, so there will be a high chance of this bacterial colonization. So, is there means what are the suggestions for the postmenopausal woman to prevent this kind of infection, and what are the consequences for that means to diagnose and the treatment protocol?
basically, generally, postmenopausal, we need to teach them more, or we need to coach them how to clean the genital areas. See, if they find frequent, yeah, we need to do some small Kelly's operation or all these things to erase. See, mostly what happens in our Indian patients, what we see, generally all vaginal deliveries, they'll have those wall prolapse or uterine prolapse, first degree, second degree prolapse are
Mhm.
there. We try to come to doctors, so many things. And what's happening after postmenopausal thing, the prolapse increases, and that leads to a super circulation of the bladder base, and those request to like indirectly we see a false diverticular like area, or the overcorrection of the angle, uterovesical angle, all those things leads to incomplete evacuation or incomplete voiding of urine. That leads to stagnation of urine, and that ultimately will lead to UTI. So in those cases, either generally our female patients, they don't prefer using fingers while passing urine and all. People in foreign countries, they are not used to it. They are used to it. They'll put the finger, they lift their vaginal anterior wall, and they have a nice clear voiding. But in India, we show them, we tell them, we guide them. Again, our nutraceutical supplements are there. They help them. But only thing first, there needs to be correction of the structural defect which is coming, and subsequently it will go on increasing. The problem is that with the postmenopausal ladies, and cough and all these things keep on increasing the prolapse, and prolapse of the bladder, what we call as cystocele, they go on increasing. If cystocele is associated with urethrosil, so they both are just like icing in the cake, and they go on increasing, and it becomes a fodder for the physician as well as for the surgeon. And surgeon, okay, they love to do the operation, and with treatment with estrogen based ointments, for some time we repair the vaginal and the anterior floor, what we call it as anterior colporrhaphy, along with vesicular, or else we can put slings. If she is already wall prolapse with uterus removal, or we have to open, we have to give Khana's sling, or anterior slings are most common. We do this operative manipulation also if the severity is very high, or else we just leave them and just coach them. If it is low, less, or if not that much of cystocele or enterocele is there, then we just allow them, we coach them, or ask them to take medications, or whenever they feel burning, they come to us, they get the testing done, and we just give the light nutraceutical, like your D-mannose containing, or your arsenic acid containing medications, and they get happier with it.
Thank you very much, sir. And sir, last one question. Uh, Yes. Sir, last one question is, so is there any protocol means in case of means when to use this antibiotics in all the cases of UTIs, or is there any specific kind of things that this way you can use these antibiotics, or in the non uncomplicated cases only some other medications can suffice to reduce the chances of UTI? Is there any protocol or something? or based on the clinical symptoms only, we need to prescribe the antibiotics and some other medications also to
To
get the
decide
successful
whether it
outcome.
is a, complicated or non-complicated. Complicated, irrespective of whatever we need to give medications. And we have got all amoxicillin group, cephalexin group, norfloxacin group, ofloxacin, orizol group. Those groups are there. They help us a lot. Second group, if it is asymptomatic or non-complicated, there we need to take care of which type of organism is there. If it is organism which is of low virulence, we ask them to flush it out with water and lemon juice and all these things. If that is not taken care by another 2 to 3 months of follow-up, then we need to put them on lighter antibiotics like sulfamethoxazole or nitrofurantoin, all these things. And if still after one or two rounds of antibiotic, then we need to raise our level of antibiotic. Ultimately, we need to take care of this UTI, because if we don't take care of UTI, or if we don't see that UTI is taken proper care of, it will go for ascending infections like pyelonephritis and lastly glomerulonephritis and kidney damages. And nowadays, after China has stopped like selling kidneys to India, now getting kidney transplant has become very difficult. Since China was there, it was very easy for Indians to get a kidney at around 2 to 3 lakhs or 4 lakhs. We used to get the full package and we used to send our patients and get it transplanted. But now we don't get it so easily. So
Thank
that
you,
is
thank you very much, sir.
grade the patient, and then we need to, and everything has to be done in a protocol based theory. See, we are basically, I'm from America, and basically at John Hopkins, each and every treatment is done with a protocol. You cannot do just because you are a gynecologist or you are a professional, you can treat according to your way. No, it doesn't work. We need to have a protocol, and with this, if the patient is like this, we need to treat like this. But that's it. And we get a very good result with our way of treatment.
Thank you very much, sir, for such a nice discussion on this emerging topic. So I could not find any other question, sir.
Yeah,
So
Sumanji, with Sir Bharat here, with your permission, can I ask one question, sir?
Sure, sure, not 100.
Yeah, thank you so much. Thank you so much, sir. Sir, especially in kidney stone patients, and this is also leads to urinary tract infections while passing the debris. So in case of lithotripsy kind of surgeries cases, sir, in that cases, sir, have you prescribed UTI flush, and what is your experience, sir?
Very nice question you have asked. You have just taken the word from my mouth only.
Thank you so much, sir. Thank you. Please, sir.
Such a nice lovely. See, basically, we need to understand why this nephrolithiasis has happened. It is ultimately because of low intake of water, or when the kidney they doesn't get adequate water to flush out. Like if you take example of a tea, when we are taking a tea, we add little sugar. And what happens to the sugar? If we just spin it out with a spoon, it dissolves, isn't it? But if we add some more sugar, it takes more time. And if we add some more, it won't dissolve.
Yes.
And then what happens? You leave it for one day. The next day you will find a big chunk of sugar bowl. So same thing happens in kidney. Now coming to the fact. See what happens. See, well cut diamond or with well cut sugar, they don't have edges much. But a stone forming or a like all those lithiasis thing, when they are formed, they are formed with spicules. And these spicules, they are very much corrosive and corroborative to the injuring to all urothelial system. These all the urothelium from kidney till bladder base, they got punctured by these spicules of the stones, and they cause what worst we expect. That is why, see, even if we think that okay, fine, lithotripsy is very easy, but a very small, one easy going thing, it's not that easy. Just to take care. That is why, see, many a times we need to give some supportive whenever we are treating lithotripsy. We give forced diuresis. We need to take care of forced diuresis, and we need to see that patients should not get again stuck with this sludge. This sludge of kidney stone, they may get stuck into the three junctions which we have got strictures. And if these six structures along with the spicules, they will traumatize the stricture portion. And that leads to a bigger structure. because the healing of this urothelial injury will be by fibrosis only. And fibrosis will lead to another stricture formation. That is why, see, it's very easy to say, but UT first advantage with the what happens, it increases or it like changes the pH of the lithiasis, the stone formating thing. If basically all with these things are formed in the basically acidic urine, and when this ursolic acid and this along with your UT flux which contains all these things, when these things have been taken, what happens? This changes the pH, and that leads to either partially or it does not allow the crystal formation to take place itself. But this is the advantage of your UT flux, and that is why I prefer more, especially in our postmenopausal ladies and all. I prefer this UT flux more than any other drugs.
Thank you, sir. Thank you so much for addressing this query, sir, because it will be helpful for us to discuss with many of the doctors also.
Yeah, that is why whenever we see, we need to understand the basic pathology. Got it? And we need to see which medicine is best in our market, rather than which company comes to us or which company doesn't come. That makes a secondary thing. The first thing is I need to treat my patient in my own way, and patient should be the most blessed person, because it is this patient who carries my name. Is it?
Very true, sir. Very true, sir.
Second, more than that, see, whenever we see medical product or medicines which helps in our treatment protocol in the best possible way, obviously we'll choose. Why I choose UT plus? That is why, because we get so much of advantage with all these things, isn't it?
Yes, sir. Yes, sir. Thank you so much, sir. Definitely, it is very valuable, from your side, feedback and clinical experience from your side. So it will be helpful for us to further we can discuss with the clinicians, sir. It will be helpful for us, sir. Thank you, sir. Thank you so much.
Thank you very much.
Thank you very much, sir, for such a nice discussion on this very important topic. And in future also, we look forward for some valuable talk from you, sir, on our Shield Connect platform for discussion. So thank you very much once again, sir, on Shield Connect.
Thank you.
Sir, thank you. খুব ভালো হয়েছে, sir. Thank you.
Now Biplava has become clear. I think.
Thank you, sir. Thank you so much, sir.
Thank you. Thank you.
The really nice, excellent presentation, sir. Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you, sir. Have a nice evening. Thank you, Biplavji, and thank you, Sumanji.
Thank you, sir. Thank you. Good night, sir. Good night, everyone.
Good night, sir.